So I would like to introduce our next speaker, Charles A. Taylor. He will be talking about the digital twins for diagnosing and managing coronary artery disease. Thank you, Charles.
Great, I'll get started. Okay, well, it's very nice to join all of you. I'm very happy to be talking about this subject. So is that my faculty disclosure? So I started my career at Stanford. I'll talk a little bit about my background, but my potential conflict of interest. I'm a shareholder of HeartFlow Incorporated. There's a company that I started in this space. I guess probably everybody's familiar with the NASEM definition for digital twins. I'll talk about this at the very end. I'll talk about the kind of the context and the technologies that I've worked on developing, and does this meet the definition for digital twins? But obviously, I presume everybody's familiar with the NASEM definition. So the reason why I am at the University of Texas, I guess, is two things. One is, and I'll talk about it in a minute, but one of them is that we have a new hospital that we're building. Austin, as a city, does not have a major academic medical center. It's the 10th largest city. We're building a new healthcare center, a new medical center, actually, two hospitals, one focused in cardiovascular neurology, complex surgeries, and the other is in MD Anderson Cancer Hospital. But our plan is to be able to incorporate medical digital twins really from the ground up, from a planning phase. So this is a really exciting opportunity, exciting project to be thinking about how we bring digital twins into healthcare. The Odin Institute at the University of Texas does a lot of work broadly in digital twins and also AI for science for a variety of different problems. I think later in the day, you're also going to hear from Tom Yankeloff, my colleague working in computational oncology. My work, broadly in this field over the last 30 years really started out at Stanford. I guess started out in an era where we didn't have the NASEM definition. People weren't talking about medical digital twins, but what I was really focused on is bridging the gap between medical imaging, creating patient-specific models of the cardiovascular system for a variety of different clinical problems. I was a professor in departments of surgery and also bioengineering, and did some of the work in patient-specific modeling of blood flow. The next phase of my career was really focused on 13 years at HeartFlow, the company that I founded, first FDA-cleared, digital twin for heart disease, reimbursed by all private insurers in clinical practice guidelines, and now has been used in over 500,000 patients and over 1,500 hospitals. At the University of Texas, I'm focused on building better digital twin models for the heart and also for lung diseases, and in joint between this, I'm a professor of internal medicine, also computational engineering and science. 25 years ago, when I was starting to think about imaging, and again, pre-digital twin era, the idea that I had is that if we could use medical imaging, diagnostic data to create patient-specific models, anatomy and physiology, develop planning software tools, then we could actually enable physicians to design improved patient-specific treatment plans. And this is really a motivation for a lot of my research, in the subsequent years at Stanford, work at HeartFlow, and then now at University of Texas. So my focus is on really after the last 15 years has really been on coronary artery disease. And of course, it's one of the primary heart diseases, atherosclerotic buildup in the coronary arteries that provide the blood supply to the muscle of the heart, can lead a patient to have symptoms or chest pain symptoms. If the plaque is disrupted, plaque ruptures can form a clot, and then the major reason why patients have heart attacks or myocardial infarctions is due to atherosclerosis in the coronary arteries. So very important clinical problem, leading cause of death. The challenge from a clinical perspective is that if you have a patient who you suspect has coronary artery disease, they're perhaps symptomatic, and there's a range of different symptoms that they might have. The dilemma is to know whether for that specific patient, they have clean coronaries, they know coronary artery disease, they can go home. They have mild to moderate disease that could be managed with medical therapy, or they have more significant disease, higher risk of having a heart attack, and these patients need to go on for further invasive assessment, maybe an intervention with stenting or bypass surgery. And roughly, if you look in a patient population with suspected coronary disease, symptomatic patients, and you image them and really go to detect coronary disease, you'll see about a third of them have no coronary disease, about a third need medical management, and roughly a third it's warranted to go on for further invasive evaluation. The right structure and to be thinking about testing is to start off with risk factors, to do stage testing where based upon risk factors to identify patients that might benefit from a non-invasive test, often non-invasive imaging test, to evaluation. And then the goal of the non-invasive testing is to decide if the patient needs further invasive evaluation or they could be managed based upon the information you have from risk factors and non-invasive testing. And if you have a low, risk of coronary disease, relatively low, you can think about lifestyle changes, statins, antihypertensives, et cetera. More aggressive medical management is required for some patients. And then, for the very high risk patients, it's often warranted to consider coronary stenting or surgery. So the difficulty is that if you try to diagnose with non-invasive testing, diagnose coronary disease, traditional tests, there's no direct view of the coronary arteries. An echo, stress echo looks at wall motion abnormality. A SPECT or PET imaging or perfusion imaging is looking for a perfusion deficit in the myocardium, a deficit of flow, again, not directly visualized in the coronary arteries, or a treadmill test with the EKG is looking for essentially an electrical disturbance in the heart, not directly looking at the coronary arteries. So the difficulty has been that oftentimes when a non-invasive functional tests are positive, more than half the time that patients are then sent for an invasive angiogram, they have no evidence of atherosclerosis, no obstructive coronary disease. But even more challenging are patients that have a negative test, a negative functional test, are sent home and their coronary disease can be undetected. It could be significant coronary disease. So there's a real challenge within a traditional non-invasive testing paradigm in cardiology. So because of these limitations, often patients go directly on for further invasive evaluation. And this is considered to be the gold standard evaluation of coronary disease. But it requires typically an invasive catheterization either in the groin or the wrist. A catheter is put in and angiogram images are obtained. And you can see a patient who has no obvious narrowing would be called non-obstructive or normal coronary artery. A patient with a diameter stenosis greater than 50% is typically referred to as having obstructive coronary artery disease. So you don't know whether when a patient enters the cath lab, whether they're going to be normal or whether they're going to actually have disease that could really, where they could benefit perhaps from that trip to the catheterization lab. Nowadays, the gold standard for invasive testing also involves a pressure wire put into the coronary arteries to be able to look whether the disease that is anatomically obstructive in an angiogram is actually functionally limiting the blood supply to the muscle of the heart. And the gold standard test is called fractional flow reserve, or FFR. And that involves a pressure wire where the pressure is measured downstream of the area of disease and also upstream in the piece of P for proximal is typically measured in the aorta, at the root of the aorta, when you pull back the pressure wire. So, and this is done under conditions typically induced by intravenous or intracoronary adenosine to mimic high flow or high, physical activity. When this pressure ratio is greater than 0.8, it's deemed to be non-ischemic or negative test. If it's less than 0.75, it's deemed to be clearly positive or clearly ischemic. The myocardium is being impacted by the disease in the coronary arteries, and in between 0.75 and 0.8 is a gray zone. So again, this test, FFR, is a gold standard for invasive physiologic testing, and it's because it's been shown that if you treat patients based upon invasive physiology assessment, then you can reduce all-cause mortality. You can improve patient outcomes by doing this versus conventional testing with an invasive angiogram. Again, gold standard level 1A evidence in the US clinical practice and cardiology guidelines. The difficulty is that this requires invasive cardiac catheterization. only about 40% of patients that enter the cath lab have a finding of obstructive disease and anatomic narrowing on angiogram. And those are the ones you're going to put a wire through into. And only about 40% of the patients where you measure FFR, these patients with obstructive disease, have a positive functional test. Those are the patients with both obstructive disease and a positive functional test that really need to be in the cath lab, will most likely benefit from a treatment in the cardiac catheterization lab. But again, 0.4 times 0.4 is just 0.16. So the vast majority of patients entering into the cath lab considered for anatomic and functional testing will be negative. And the question is that can we do this and identify obstructive disease and quantify fractional flow reserve before the patient goes to cardiac catheterization? And the anatomic test nowadays can be provided non-invasively with a coronary CT scan. It's remarkable how much this technology has improved over the years. A very high quality data. But the big challenge, the question is, how could you get fractional flow reserve non-invasively actually from a CT scan? This technology, it's called FFR subscript CT. The naming convention came from the inventors of invasive fractional flow reserve. And again, I invented and developed this technology and called it that based upon at the request of the inventors of invasive fractional flow reserve. So it's fractional flow reserve derived from a CT scan. There now are 2 FDA-cleared products. There's a number of other technologies, research technologies that have been used, and I'm sure other products coming forward. But there's now 2 FDA-cleared products for this. I'm going to tell you a little bit about how it works and how you build an anatomic model from imaging data, the physiology, computational physiology, the prediction of blood flow through the coronary arteries, and then I'll talk about how this is used for clinical decision-making in practice as well. So this is the hardest part of the problem because CT data, trying to build a patient-specific model of the coronary arteries for medical imaging can be challenging. The heart's moving, the coronary arteries are relatively small. You need good spatial resolution. You need good temporal resolution of the imaging because of the trying to image the beating heart. And then when you have atherosclerosis, and this is a very heavily calcified coronary arteries in a patient, you have to extract this information and create, this digital twin for these patients. So often very difficult to do this. Sometimes you have poor contrast timing and poor opacification, calcium movement, et cetera. It's very challenging. So the question is, what's the role of AI here? Obviously, there's a lot of advances in artificial intelligence. I mean, we're seeing a lot of this in computer vision. In different AI technologies, computer vision is a relatively mature area of AI, and nowadays we think about deep learning as computer vision approach. There's an approach used in computer vision. And the question is, what do we do about this? There's been a lot of comments made about how this is going to ultimately displace radiologists in the field. And this quote from Geoffrey Hinton, who we all know won the Nobel Prize in Physics last year. But he was quite frankly pretty bold in this statement that deep learning is going to do better than radiologists. We should stop training radiologists. Bill Gates, I think, unfortunately, has the view that none of us will be necessary. Doctors and teachers within 10 years, humans won't be needed for most things. I find that a little bit humorous. But again, these 2 people have their opinions. So the question that I had is that what do the real experts think? So I asked ChatGPT, will AI replace doctors in 10 years? And actually gave me a very measured and balanced response. Maybe it was what it thought I wanted to hear. But I think what is true is it'll dramatically change how doctors work. There obviously are things in terms of supporting analysis of medical imaging, a variety of different technologies, but obviously it's an assistant, not a substitute. And obviously human AI collaboration is important. So 9 years after Geoffrey Hinton's comments, we have a radiologist shortage. And the truth of the matter is that when you have better imaging, you do more imaging, we have better ways of analyzing imaging data. What happens is not that you displace radiologists, but you generate a lot more imaging data, a lot more information that needs to be interpreted. And I think it's actually really important to leverage AI technologies in this space. So how do you put it together? And I'll just tell you what I worked on or what I did and how you combine artificial and human intelligence to build digital twin models for the coronary arteries. The first part of the process is if you want to extract information from images like this, non-invasive images like CT, if these patients go on to invasive procedure, invasive cardiac catheterization, where you can get gold standard invasive data, then you can overlay the invasive and non-invasive data. You can't interpret medical images like this if you don't have ground truth, and it's very hard to know what the ground truth would be for something like this. But if the patient goes to the catheterization lab, you can do intravascular ultrasound, overlay it with CT. These are cross-sectional areas down the length of the vessel. You can overlay the portion where you have invasive gold standard data with the non-invasive data. You can use that to teach an algorithm to basically set parameters on an algorithm to improve the extraction of information from the non-invasive data. So this is another example of this, a study that we published in Neurointervention now 6 years ago. You see along the length of the coronary CT scan, you see all the coronary calcium, these cross sections 1 through 4. You see the cross-sectional data. It's very hard to know where the boundary is because of the calcium blooming. You can see this beautifully with intravascular imaging, in this case, optical coherence tomography. If you overlay the OCT and CT data, fuse the data together, you can do direct comparison on a cross-section by cross-section data, and you can then use the invasive imaging in your training data to improve your non-invasive interpretation. So that's the first step. The second step is and this is what we did, is that we built a visualization system where you could look at the automated algorithms, results of automated algorithms embedded into the image data, and then you do inspection and correction. And at HeartFlow, what HeartFlow did is basically set up a system, train people to interpret medical images, to run the software and to basically annotate data. So if you do that, you extract large structures, center lines from the coronary arteries, the inner boundary of the blood vessels, that every step of the process, if you have a person reviewing, inspecting, and correcting the different steps of the process, they're corrected, a re-annotated data set can get fed back into future generations of the algorithms, and those corrections are used to produce a result for an individual patient. So every case you do, you have a new annotated, corrected data set that you can then feed back. Now, of course, there's a lot more to the story than just this. There's, training people, developing a systematic, essentially manufacturing process for the interpretation of medical images. That's an important part of the process. So then this is again creating an anatomic model, bespoke anatomic model for an individual patient. The physiology approach that I took is to basically use the anatomic imaging information from the anatomic imaging to infer physiology. So in this works because of form function relationships. The amount of myocardium we have, amount of heart muscle is related, basically dictates the amount of coronary flow that is required. So there's a relationship between total coronary flow, a physiologic parameter, and anatomy. And likewise, the distribution of flow through the coronary arteries is very much governed by the relative size of the coronary arteries at different stages of the coronary artery tree. And every patient's coronary artery anatomy is different. But every vessel in our coronary arteries, every single vessel is adapting and responding to the amount of flow. So if we can go work backwards from the anatomy to infer functional data. And then you can model the vasodilatory effect of the drug, intravenous adenosine, used to produce maximal hyperemic conditions. And when you get to maximum doses in intravenous adenosine, you get a plateauing of the dose response, minimal variability between patients, and essentially get this reproducible response that you can then use to model physiology. The last part is the solving physical laws of fluid dynamics, and this is what I worked on for 15 years at Stanford developing computational models to extract and quantify blood flow through the coronary arteries. There's a lot of math involved, but it's relatively straightforward to do this. And nowadays with modern computing capabilities, surrogate models, you can do these calculations in a fraction of a second. You can produce non-invasive data along the whole coronary tree. You can directly validate it with patients that go to the cath lab with invasive pressure measurements, direct comparison. And this is what's required to bring a product in this class to market, is to provide accuracy data to the FDA. This technology there's been over 600 publications, more than 100 clinical trials that have been done so far. Many of these investigator initiated, but a whole series of accuracy trials, outcomes trials, very large clinical trials. This is the accuracy trial, a fairly recent accuracy trial published in 2019, which was direct comparison using invasive fractional flow resurface, the measure. This is a clinical trial and outcome study done in patients that had no cardiac history or symptoms. They were actually being treated for peripheral artery disease in their legs. They had chronic limb-threatening ischemia. Typically, if patients have atherosclerosis in their legs and their peripheral arteries, if they have atherosclerosis in the carotid arteries, they usually have it also in the coronary arteries. And this was a study that looked at the control patients that were, after treating disease in the legs, there's no further evaluation. There's no evaluation of the coronary arteries. That's control. You see only a 50% survival at 5 years due to coronary disease. If you use these computational models, then you can actually significantly improve survival. And this also works in patients with carotid artery disease. So you can actually prove better outcomes as a result of this technology. In the UK in 2016, they changed their chest pain guidelines to start with anatomy first, followed by functional testing or functional imaging. This is the update to the chest pain guidelines. FFR-CT received a positive review from NICE, the National Institute for Health and Care Excellence in NHS in 2017. There was a period of 3 years where NHS basically provided funding to introduce into their healthcare system. In 2021 was one of the first products to be mandated by National Health Services in England. You see the front page of the London Times talking about a new scan finding heart disease. As a result of this, there was an NHS study as published in Nature Medicine looking at what happened when you introduce the technology in their healthcare system. It was in over 90,000 patients. They showed that it was safe, no difference in all-cause mortality, but a reduction in invasive angiograms and also reduction in downstream non-invasive cardiac testing, which is obviously was really important in the NHS healthcare system. In 2021, it was this FFR-CT was the first AI medical product to be included in the American College of Cardiology and American Heart Association clinical practice guidelines. So in patients with intermediate coronary disease, where you start with a CT, then it calls for functional testing based upon the anatomic findings. It's regulated as simulation as a medical device by the FDA. There are many AI-cleared products now, FDA AI-based medical technologies. You see most of these in radiology, second in cardiology. The challenge is that most of these AI products are not being paid for by Medicare, directly reimbursed. And you see really the vast majority. Once you get through the top 10 technologies, there's very few Medicare claims data. So the real challenge is not getting regulatory clearance. The challenge is getting it integrated into healthcare systems through reimbursement pathways. Now, in addition to physiology, there's products to do anatomic assessment and quantitative plaque. There are 3, I think now there's a 4th FDA-cleared AI quantitative coronary plaque analysis product. This is the one from Clearly Labs. This is from a company called Elucid, again, providing AI quantitative plaque analysis, and this is what HeartFlow provides for AI quantitative coronary plaque analysis. This technology was validated with intravascular ultrasound in a study published in European Heart Journal Cardiovascular Imaging. The primary endpoints are really looking at accuracy for non-invasive quantification of plaque versus intravascular ultrasound. And starting actually, I think it's just there's a category 1 CPT code that is now effective. It might be effective actually January 1st of 26. But now there's these technologies are being introduced and being paid for in the healthcare system. From a prediction perspective, you can actually, once you have a computational model or a digital twin, you can use this to do real-time interaction and planning of stenting, percutaneous coronary intervention. This is an FDA-cleared product to predict physiology after a stent implantation. This is validated in a clinical trial with motorized pullback of fractional flow reserve. There's a large randomized control trial that is just fully enrolled. Next year we'll get the results of 1 year primary endpoint of death MI or ischemia-driven target vessel revascularization, and a little over 1,000 patients. So this is testing a hypothesis of CT-guided PCI or digital twin-guided PCI versus conventional testing. It's now in the clinical practice guidelines in the journal, the Society for Cardiovascular Angiography and Interventions. And also there's been papers out there on demonstrating the use in bypass grafting. So I'll just close with again, I started this technology not thinking about digital twins. I think it fulfills most of the criteria. It's typically not dynamically updated. It can be updated when you do subsequent imaging studies. It's just not something that's happening in real time. It's not continuously updated, but I think it meets the other criteria. And importantly, it's in clinical practice. It's in guidelines. It's cleared and paid for. And I'll just close with financial support. The support of this technology really came about from National Science Foundation and National Institutes of Health grants for Stanford and then ultimately at HeartFlow to be able to fund the science that went into this. And happy to answer some questions if there's time. Thank you.
Thank you, Charles. Please put your questions in the Q&A. Actually, I have a question while others are typing. What do you think was the most successful moment? I mean, I think right now you're showing us our dream. A lot of our initiatives are hoping to get where you're at and at least push further. So when was that moment where you said, "Wow, we're almost there"? And what do you think
I don't
led
think
to
it
it?
happened until it went public, to tell you the truth. I have to say there were many near-death experiences along the way. I didn't know if it would actually be successful until that happened. But in reality, it wasn't FDA. At every stage of the journey, you think about, well, great, we have FDA clearance. That's a big step. But then 3 years later, 4 years later is when you get Medicare payment. It's a long time. And then every step of the journey, there's barriers, there's existential near-death experiences. But it's, in the end of the day, I think probably, for me, when the company went public and I stepped off the board and I felt like there was time to start to think about the next thing. But, I believe in why I'm, back in an academic role at the University of Texas. I believe there's hundreds of stories like this that could happen. I think we'll see, maybe fast forward 10 years, 5-10 years from now, I think there'll be many successful stories of digital twins, including those that are, fully meeting the NASEM definition. But I think those will be in clinical practice. And I think it's going to be great for patients in the end of the day. For me, the most gratifying thing is when a physician tells me that they changed how they practice medicine, or it's been 500,000 patients or so that have received the test. That's what matters the most in the end.
So we do have a few questions, but I actually love the part where you said, AI should be leveraged and just,
Yeah.
not
It
not a
should be AI in
substitute,
the
but an
human
assistant,
loop.
right?
Actually,
Yeah.
I think I feel like I need to correct this idea of human in loop AI. It should be AI in the human loop. And it's a very powerful tool. And, I think many my radiology colleagues will just say that like AI is not going to replace radiologists, but if radiologists that use AI will replace those that don't. And I think that's the message probably is that all of us should be thinking about, new technologies like this and how it can improve the work that we do. And I think we're going to see a lot of it. There's a lot of excitement.
Well, thank you.